I and some of my colleagues started a specialized clinic where we see essentially patients who have autoimmune muscle disease and some of the other systemic manifestations that go along with it. And my primary collaborators in the clinic are a rheumatologist by the name of Lisa Christopher Stein, who some of you from here may know, and a pulmonologist named Sonia Danoff. And then in the lab, some of my close collaborators are Livia Casciola-Rosen and Antony Rosen. And so the work that I'm going to be presenting today really represents a collaborative effort of that group of people and the patients that we've seen at the Myositis Center. So I'm going to be talking about statin-associated autoimmune myopathy, which I guess is a fairly timely topic given all the news about statins this week. I'm going to start off by giving you just an overview of the autoimmune myopathies, because they're really a family of diseases. I'm going to talk about some of the autoantibodies that are associated and specific for patients who have autoimmune myopathies. And then I'm going to talk about the expression of the autoantigens recognized by these autoantibodies in myositis muscle versus normal muscle. So that'll be the beginning, sort of background. And then I'm going to move on to talk about some recent work that's been going on based on these patients that we've seen at the Myositis Center here. So the first part is just to sort of tell you a little bit about how these patients present. Although it is a heterogeneous group of disorders, most patients with autoimmune myopathy present with symmetric proximal limb weakness. So they have difficulty getting their arms above their head, difficulty going upstairs, difficulty getting out of a low chair. This usually occurs on the order of weeks to months. It develops over that time period. Patients who are severely affected can develop problems with swallowing or problems with breathing, sometimes requiring PEG tubes or intubation. Many of these patients will have an overlap with another autoimmune disease. So patients can have an autoimmune myopathy and scleroderma or and lupus. Fortunately, most of these patients do respond to immunosuppressive therapy, some better than others. And these are really relatively rare conditions. So it's thought that probably there's about one new case per 100,000 people per year. I think it might be a little higher than that, but it's definitely a rare category of diseases. And another clinical thing I wanted to tell you about, because I think it may be related to pathogenesis of the disease, is that patients with autoimmune myopathies have an increased risk of malignancy, particularly adenocarcinomas. And that'll come up later. There are basically two main categories of autoimmune myopathy. The first is polymyositis, where the muscle is the predominant organ system affected, usually. And there's a version of that called immune-mediated necrotizing myopathy, which I'll tell you about. And then the other broad category is dermatomyositis. And these patients don't just have muscle involvement, but many of them also have skin involvement. And I've shown you some examples here of the pathognomonic rashes that are seen in these patients. This is called a heliotrope rash, which is this violaceous rash on the upper eyelids of this patient. And then here you can see what are called Gottron's papules, which are these erythematous eruptions over the extensor surfaces of the MCP, PIP, and DIP joints. And these are really pathognomonic for dermatomyositis, not seen in other rheumatologic or dermatologic conditions. So I want to just share with you what normal muscle looks like, because I'm going to show you what diseased muscle looks like in a minute. This is a cross-section, an H&E section through normal muscle. And what you can see is here we have a fascicle of muscle fibers cut in cross-section. So in here are individual myofibers. I want you to note that they're all about the same size. There are no inflammatory cells in this muscle. There's no degenerating or necrotic cells in this normal muscle. And these are multinucleated cells. So you can see there are little purple dots along the rim of each individual myofiber, and those are the nuclei of these really large multinucleated cells. So these two pictures are from patients who have dermatomyositis, and they show the characteristic features of that disease. This is a low power view, and it's showing multiple fascicles. And what you can see, what I want you to see is on the inside of the fascicles, the myofibers have a normal size diameter, but on the outside of the fascicles, the fibers are atrophic. And this is called perifascicular atrophy. It's really pathognomonic for dermatomyositis. You don't see it in other forms of autoimmune muscle disease or genetic muscle disease. So when you see that, it's dermatomyositis. The other characteristic feature of dermatomyositis is inflammation, particularly around blood vessels. So this is a picture of a blood vessel surrounded by lymphocytes. These are largely CD4 positive cells. And it turns out there are a lot of interferon-secreting plasmacytoid dendritic cells surrounding these blood vessels as well. So that's the characteristic feature of dermatomyositis when you perform a muscle biopsy. In contrast, in polymyositis, the really characteristic feature are normal-looking muscle cells that are surrounded and invaded by CD8 positive cytolytic T cells. And this is an example of primary inflammation here. You can see this in other things, but it's very characteristic of polymyositis. So polymyositis and dermatomyositis, probably different diseases, even though the weakness looks very similar in the patients when they see you in clinic. The last kind of muscle biopsy I want to show you is a necrotizing muscle biopsy. And in this case, what you see are lots of degenerating and regenerating muscle fibers and necrotic muscle fibers, but you do not see lots of inflammatory cells. They're very scant lymphocytes in these muscle biopsies. And when we biopsy people and we get this type of a picture, we're often confused about what the etiology of the disease process might be because it's a nonspecific finding. So you can see this in some patients. You could see something like this in a dystrophy. You could see this in a patient who has an inflammatory myopathy where you've missed the areas of inflammation just due to sampling error because the disease is relatively patchy. And also, sometimes a toxic myopathy could look somewhat like this. And there are lots of reasons to have toxic myopathies. We give patients lots of drugs that could potentially cause muscle damage. One of the most commonly prescribed ones are the statin medications. And patients who develop severe muscle weakness while on a statin, if you biopsied them at the time of the statin exposure or shortly after, they might have a muscle biopsy that looks something like this as well. Although I will say with typical statin myopathy, once the statin is stopped, you expect the patient's symptoms to resolve and get better over the weeks or months after discontinuing the medication. But you can also see this as part of an autoimmune process. All right, so those are the three different kinds of muscle biopsies I wanted to tell you about. The next thing I wanted to tell you about are the autoantibodies associated with the autoimmune myopathies. And the key thing I want you to get out of this is that each of the individual autoantibodies is associated with a unique phenotype. And I think I think of there as being three separate classes of myositis-specific autoantibodies. The first are the antisynthetase antibodies. There are about 8 of them, and I'll tell you more about them in a minute. Then there are a group of autoantibodies that are specifically associated with dermatomyositis, not found in patients who have polymyositis or immune-mediated myopathies. And then finally, there is an autoantibody that really strictly recognizes or is very specific for patients who have immune-mediated necrotizing myopathy. And in that case, it's a good marker for that being an autoimmune process. So I'm just going to run through a couple examples. So the aminoacyl-tRNA synthetases are, as a group, myositis autoantigens. And what these proteins are the enzymes that attach the appropriate amino acid to the appropriate tRNA synthetase. So there are about 20 different tRNA synthetases, and for reasons that we don't understand, about 8 of them are specifically targeted by the immune response in patients who have autoimmune myopathies. And patients who have these autoantibodies don't just have muscle disease. They actually have a whole clinical syndrome that's characterized by the findings on this slide. Probably the most important thing is that they frequently will have interstitial lung disease, an autoimmune interstitial lung disease, which can really be devastating because unlike muscle, lung does not regenerate very well. They also can have a non-erosive arthritis. They frequently have Raynaud's phenomenon, which is where you get vasoconstriction of distal arteries in the fingers that cause your fingers to turn white temporarily. And then they get a characteristic rash called mechanic's hands, which are these hyperkeratotic lesions. So again, this whole syndrome is very highly associated with these antisynthetase antibodies. The second one I want to tell you about is the signal recognition particle. So it turns out that the signal recognition particle is also a myositis autoantigen. And this is also a protein that's involved in it's a protein that's involved in the whole protein production pathway. The signal recognition particle is composed of about 6 protein subunits, and it recognizes the N-terminal signal sequence of newly translated proteins and helps move the appropriate proteins to the endoplasmic reticulum. So again, like the tRNA synthetase is found in all cells, but for some reason specifically targeted in the autoimmune myopathies. And patients who have this have also a unique phenotype. So instead of having inflammatory muscle biopsies, these patients have necrotizing muscle biopsies. So it's really specific for an immune-mediated necrotizing myopathy, and it's often a very severe and difficult to treat form of autoimmune myopathy. The last one I want to tell you about is an enzyme called Mi2. It's a chromatin remodeling enzyme. It's part of the nucleosome remodeling and deacetylation complex. And again, for reasons that we don't understand, it is specifically targeted in autoimmune myopathies, and not all autoimmune myopathies, but strictly in dermatomyositis. So about 30% of dermatomyositis patients will have this autoantibody, not found in anything else. So, one of the questions has been, these myositis autoantigens that are recognized by the immune system are found in all cell types. So why would they be specifically targeted in myositis? And I think that there's some clue that may come to looking at the expression of the autoantigens in the tissue that's targeted by the disease. And the work I'm going to show you was really done by Livia Casciola-Rosen before I came to the lab. And she looked at a number of different autoantigens in normal muscle and in muscle affected by one of the autoimmune myopathies. And I'm just going to show you the example for Mi2, where they've taken muscle lysates, run them out, and done immunoblotting with an antibody against Mi2. And what they found is that there's very little Mi2 expressed in normal muscle biopsies. Normal muscle has very low levels of Mi2 expression. In contrast, if you look at dermatomyositis muscle lysates, they have high levels of Mi2 expression. Polymyositis has slightly higher levels than normal, but really it's especially highly expressed in patients who have dermatomyositis. And again, that's the group of patients who develop the autoantibodies against this protein. So the idea is it may be upregulated in the tissue that is the target of the immune response. When I came to the lab, one of the things I was interested in is trying to find out which cells in the muscle were expressing the high levels of Mi2, because remember, in a given muscle biopsy specimen, you might have normal muscle fibers, degenerating muscle fibers, regenerating muscle fibers, blood cells, so forth. And I decided to look to see which cells were being had the high levels of expression of Mi2. And in these panels, you're looking at muscle biopsy from a patient with dermatomyositis, and in red, we're staining with NCAM, which specifically stains regenerating muscle fibers. And you can see around the edges of the fascicle here, there are lots of regenerating muscle fibers. And as you move inside the fascicle, there are fewer and fewer of these. And when we looked at Mi2 expression, what we found was that the nuclei of the regenerating muscle cells had very high levels of Mi2, much more than we saw in the inside of the fascicle, where there are normal-sized and not regenerating muscle fibers. So in the case of DM muscle, it's the nuclei of the regenerating perifascicular myofibers that express the high levels of Mi2. And this has been shown for a number of different autoantigens. Some of the antisynthethases and SRP are the same way, where you have low levels in normal muscle but high levels in the regenerating muscle from the diseased tissue. And the other interesting fact, and I'm not going to show you the primary data for this, but again, this is work done by Livia Casciola-Rosen, is that if you look at tumor tissues, they also express very high levels of the autoantigens. We think this is particularly interesting because there's this increased risk of malignancy in patients who have the autoimmune myopathies. And an example of this would be Mi2, the example I've showed you before, and it's found at very low levels in normal breast and lung, but at very high levels in the tumors that are associated with the disease. So this has led to a model. This is a model that was developed in the Rosen lab, and they were kind of working on and trying to determine whether it's correct. But the model here is that tumors, unlike normal tissue, express high levels of autoantigens, and that there may be an anti-tumor response to try and eradicate the tumor that results in an immune response against some of these myositis and other autoantigens. And under normal circumstances, that immune response doesn't go anywhere besides against the tumor. Normal muscle doesn't express very high levels of these autoantigens. But under certain circumstances where there is muscle regeneration, the immune response may be redirected towards the regenerating muscle. And the idea here would be that the regenerating muscle is a target of the immune response. The immune response causes more muscle damage, and it becomes sort of a feed-forward loop where you get more muscle damage, more regeneration continues to fuel the immune response. So again, this is just a model, but one that we've been working with for a while. And it seems there's evidence from other types of autoimmune diseases that are associated with malignancy that this may be a correct model. So now I want to move to talking about the work that we've been doing recently, looking and finding a novel autoantibody that's specifically associated with a necrotizing myopathy. And I wanted to start just by telling you about a patient. This is an example of a patient that we saw maybe 3 years ago. He was a 71-year-old guy who had hypertension, type 2 diabetes, and he had hypercholesterolemia. He had been on a statin for about 7 years with no problems whatsoever. In December of the year before I met him, he was put on antibiotics for bronchitis, and while he was on the antibiotics, he developed some muscle pain, some myalgias. By January, the bronchitis had gone away, but he continued to have muscle pain, and he started noticing he was developing leg weakness. By the time he saw his primary care doctor in February, his arms were also weak, and the physician recognized that, hey, perhaps this is something that's being triggered by the statin, and decided to stop the statin at that point. Despite stopping the statin, however, this guy over the next 7 weeks or so continued to get worse. And by March 24th, he was using a cane, and his CK level was about 9,000. And the CK is a marker for muscle breakdown. It's released from muscle cells as they break down, and the normal level is about 200. So this guy has really astronomically high levels of this muscle enzyme. I saw him for the first time in mid-April, and by that time he was in a wheelchair. His voice was hoarse, and he had many features of an inflammatory myopathy on EMG and MRI and so forth. And he was quite weak. We did a muscle biopsy, and the type of muscle biopsy that came back was one of these necrotizing muscle biopsies. And so that left us, there was tons of degeneration and regeneration, but no characteristic features on the muscle biopsy that would allow us to make a diagnosis. We have a differential diagnosis here. I really thought, based on his presentation, that he was just a classic anti-SRP patient with a severe immune-mediated necrotizing myopathy. So as a matter of course, we looked for antibodies, for the anti-SRP antibodies, and found out that he was negative for these antibodies. So he looked a lot like it, but he didn't have those antibodies. And that really prompted us to do a screen to look for novel autoantibodies in patients who had idiopathic necrotizing myopathy. And what we did at this time at the Myositis Center, I think we had seen 700 or 800 patients. And for 225 patients, we had both the muscle biopsy available for our review as well as a serum sample. And we found that 38 of those 225, or 17%, had a predominantly necrotizing muscle biopsy. And out of those 38, only 12 had a very definite diagnosis. So 6 of them, as you might expect, were anti-SRP patients. A handful had one of the antisynthetase antibodies, and then there were a couple other clear reasons why those patients had necrotizing muscle biopsies. But we had 26 patients where there is no known autoantibody, and we decided we'd look for autoantibodies in these patients. And the way we do that is to take HeLa cells and grow them in the presence of S35 methionine, and we label all of the proteins in the cell so they're radioactively labeled. We make a lysate of that, and then we take patient sera, which contains autoantibodies in some cases, and we see what proteins are immunoprecipitated by the patient sera. And any protein that comes down is kind of, by our definition, an autoantigen. And what we found, to our surprise, was that 16 out of 26 of the idiopathic necrotizing myopathy patients immunoprecipitated a 100 and 200 kilodalton protein that was not seen when we immunoprecipitated with control sera. And these are some examples of those patients. So, and when we look at the patients who did not have necrotizing muscle biopsies, only 1 out of 187 of those patients had this antibody. So the antibody is very highly specific for necrotizing muscle biopsies. And these patients had many features characteristic of autoimmune myopathy. All of them were weak. About 3/4 of them, which is higher than typical, had significant muscle pain or myalgias associated with the disease. The average maximum CK in our untreated patients was 10,000, very, very high. And they had other features characteristic of autoimmune myopathy, including some features on muscle biopsy with stains that are specific for like MHC1, which are specific for autoimmune myopathic processes. When we looked at whether these patients responded to therapy, we found that about 65% of them had a complete or near complete response to immunosuppression, and about 35% had a partial response. We also found that as we tried to taper our immunosuppressive regimens, many of these patients flared, about 43% flared during the taper at the time of this publication. So, the patient that I told you about had a statin exposure as part of their history. And some of the patients actually told us they were quite convinced that the statins had caused their disease. And we were kind of skeptical about this at first, but we decided to look at it very systematically. And it turns out when we look at our patients who are aged 50 years old or older, 10 out of 12, or 83% of the patients with these autoantibodies had a previous statin exposure. Not all, but 10 out of 12. In contrast, patients of the same age who have dermatomyositis, polymyositis, or another maybe autoimmune-mediated process, inclusion body myositis, had from 25 to 35% had a prior statin exposure. So there is a real statistically significant risk of statin exposure in the patients who had this novel autoantibody. Some issues about the nature of the statin use in these patients. The range of statin use before patients developed any muscle symptoms was anywhere from a couple weeks to many years before developing a problem. The precise statin that was used was variable. That's sort of hard to track down. Many patients were on more than one. The length of time between the discontinuation of the statin and when the muscle biopsy was performed, on average, was about 5 months. So those muscle biopsies are from people who are far away from their statin exposure. And the other thing is, when you looked at statin exposure, is that these patients all, like our index patient that I talked to you about, continued to get worse and worse even after the statin was stopped, and didn't get better until they were treated with immunosuppressive therapy. So we spent a lot of time trying to figure out what is the autoantigen. What is the 100 kilodalton protein? What is the 200 kilodalton protein? And we tried using sort of brute force methods to purify it and do mass spectroscopy and so forth, and we failed miserably to do that. But when we really realized about the statin exposure thing, we did an experiment that I think really helped us a lot, and that was, I told you we take these HeLa cells and we radioactively label them with S35-methionine. Well, what we decided to do was to either immunoprecipitate from untreated cells or to immunoprecipitate with our sera from cells that have been treated with statins. And what we found, I think, was really interesting, and that is that if you treat the cells with statins, you get a massive upregulation of the proteins that are recognized by the antisera. So that was a very important observation for us, because then we started thinking about the cholesterol biosynthetic pathway. And as probably many of you know, there are precursors to cholesterol. So down here's one of the final products of this pathway is cholesterol. There are these precursors, and the rate-limiting step of cholesterol synthesis is mediated by HMG-CoA reductase. And that, of course, is the target of statins. And when you treat people with statins to lower their cholesterol, what happens is you inhibit this whole biosynthetic pathway, and the levels of cholesterol goes down in the cell. Well, it turns out, this is well known, that this is a very tightly regulated pathway by the cell. And if you treat cells with statins, many of the enzymes that are involved in the production of cholesterol are upregulated. And one of them is HMG-CoA reductase itself, is massively upregulated sometimes when you treat patients with statins. So we had a few clues. One was that we know that autoantigens in general are upregulated in tissues targeted by autoimmunity. We knew that the 200 and 100 kilodalton antigens were upregulated by statin use. We knew that statins upregulated HMGCR, and then we started looking at the molecular weights of these things, and we realized that HMG-CoA reductase is 100 kilodaltons. So it seemed like a great it seemed like a great potential autoantigen. And when we went back and looked at the literature from the 90s, when people had done immunoprecipitations of HMG-CoA reductase, it was actually immunoprecipitated as a 200 and 100 kilodalton band, and thought that the 200 kilodalton band is probably a dimer. So what we did was to synthesize radioactively labeled HMG-CoA reductase in vitro, and we made a full-length version of it, and then we made a version that's just the N-terminal transmembrane part, and then we made a piece that just corresponded to the intracellular catalytic domain. Normally this protein, as far as we know, in most cells sits in the endoplasmic reticulum with this catalytic domain in the cytosol. So we synthesized these three bits. This is the full length, this is the C-terminus, this is the N-terminus, and in red we're immunoprecipitating with our known anti-200-100 patient sera, and in yellow our control sera. And what we found was that all of our patient sera immunoprecipitated both the full length and the carboxy terminus of HMG-CoA reductase, whereas none of our control sera did. Here are some examples, but it's very reproducible. So by doing this and other experiments, we were really able to confirm that HMG-CoA reductase, the target of statins, is the autoantigen in the statin-triggered autoimmune muscle disease. We did some experiments back again now in HeLa cells where we did our immunoprecipitations with and without cold HMG to try and block the immunoprecipitation. And what we showed was that if you incubate in the presence of cold HMG-CoA reductase, you block not only the immunoprecipitation of the 100 kilodalton band, but also this 200 kilodalton band. So either that's a co-immunoprecipitated protein, or more likely, we think, is a dimer of HMG-CoA reductase. So then we developed an ELISA assay, and we went back to our entire cohort to look at how prevalent these autoantibodies were in our population of patients. And we found, based on the criteria of the ELISA read being three standard deviations greater than the mean of the average of our control group, using that as a definition, 45 of our patients were positive for HMG-CoA reductase antibodies. And we did some controls and found that the sensitivity of this ELISA was about 94% and about 99% specificity relative to our gold standard, which is the immunoprecipitation. And then we looked at what were the clinical features of these patients. And the only one I'm going to really share with you now is the statin use. And what we found were that out of all comers, about 2/3 of our patients who were positive for these antibodies had been exposed to statins. If you looked at the patients 50 years and older, 92% of them had a statin exposure at the time of developing their muscle problems. And again, in patients with other forms of autoimmune myopathy, it's like 25 to 35%. So this was statistically significant, and now not so surprising, given that we know what the autoantigen is. It kind of mechanistically makes sense. The last bit of data I wanted to show you here is, again, looking at the autoantigen expression in the target tissue. So again, I'm going to stain with NCAM to look for regenerating muscle fibers, and then with anti-HMG-CoA reductase to see in which cells the autoantigen is found. Down here we have some normal muscle stained with NCAM, and there are no positive fibers. And also HMG-CoA reductase expression is very low. In contrast, if we take the muscle biopsies from our patients who have the necrotizing myopathy and the positive antibodies, they have lots of regenerating NCAM positive cells, and those regenerating fibers have high levels of the autoantigen. So in conclusion, to sort of wrap it up, the anti-HMG-CoA reductase associated myopathy we think is a novel autoimmune myopathy. In some patients, it's at least associated, if not triggered, by statin use, possibly we think through increasing the expression of HMG-CoA reductase, either in muscle or some other tissue. And even after statins are withdrawn, the regenerating muscle still makes very high levels of HMG-CoA reductase, which again we think may continue to drive the immune response even after statins are taken away from the patient. So in yellow now, we're adding some things to kind of our model of how we think about how autoimmunity against these autoantigens and myositis might be initiated and sustained. And now what we've added is statins up here as a potential trigger instead of tumors, which increase HMGCR expression. And in individuals who are susceptible for reasons that we don't fully understand develop an anti-HMGCR immune response. And again, this is targeted probably best against regenerating muscle, which expresses high levels of the autoantigens, causing further muscle damage and further muscle regeneration. And so that even when the statin is now removed, you have this sort of feed-forward loop. So I think I might have a couple more minutes. So I just wanted to share with you two little more bits of information. One is we wanted to look at how prevalent these antibodies were in just the general population of patients on and off statins. And for this project, I collaborated with some patients here at some folks, Joe Koresh and Liz Selvin at the Welch Center, and also part of the Bloomberg School of Public Health. And they had a population of patients from the ERIC cohort, the Atherosclerosis Risk and Communities cohort. And we looked at they had serum available from these patients, and we looked at a subsample. I'm not going to tell you about it in detail, but the bottom line is the subsample contained 881 statin-naive subjects who had never been on statins, 763 patients who were currently using statins, and a little over 300 who had a prior exposure to some lipid-lowering agent. And we're just submitting this now, but I was kind of surprised. We found that by our ELISA assay, about 14 of the patients appeared to be positive for the HMG-CoA reductase antibodies. But when we did what we consider to be our gold standard immunoprecipitation, none of them immunoprecipitated HMG-CoA reductase. So we think that there were none that were truly positive in that large cohort, and that these generation of these antibodies is very rare, both in patients who are exposed to statins and patients who are not exposed to statins. And the next question that we had is, what about in the patients who have self-limited statin myopathy? You know, the kind that goes away after you stop the statin over weeks or months. Did those patients also have these autoantibodies? And what we did is we collaborated with Daniel Gaudet and his group at the University of Montreal, who have a hypercholesterolemia clinic. And they gave us plasma samples from 98 patients who have familial hypercholesterolemia because of defects in the LDLR gene. And they had 51 very well-characterized patients who had to stop statins because they were statin intolerant. About a third of them had had weakness, more than half had muscle pain, and 20% had marked CK elevations or myoglobinuria. And then they gave us 47 similar patients with familial hypercholesterolemia who were tolerating maximum dose therapy just fine. And again, none of those, either the statin tolerant or the statin intolerant patients, developed antibodies against HMG-CoA reductase. So we believe that it's rarely, if ever, found in patients who don't have this more severe autoimmune myopathy. And furthermore, we think that in patients who present with muscle weakness or muscle pain on a statin, which is a large number of people, maybe as high as 10%, if you have a negative HMG-CoA reductase ELISA test, it is extraordinarily unlikely that you have the autoimmune muscle disease where you need to consider treating with immunosuppressive therapy. So those are just the last two things I wanted to share. And then again, recognize particularly Anthony Rosen, Livia Casciola-Rosen, and Lisa Christopher Stein, who are my main collaborators at the Myositis Center who helped in this work. And then also, again, Joe Koresh and Liz Selvin here at Bloomberg and the Welch Center, and Daniel Gaudet at the University of Montreal. So thanks a lot.
We have time for one or two questions.
Could this condition ever mimic or be associated in any way with inclusion body myositis?
We have 2 patients now. Oh, I'm sorry. The question is, could these antibodies ever be associated with inclusion body myositis? And inclusion body myositis is a form of myopathy that usually occurs rather late in life, affects men more than women, doesn't respond well to immunosuppressive therapy. Since a lot of them are older men, a lot of them are on statins. We've seen 2 patients who presented with severe proximal muscle weakness, which usually you don't see in inclusion body myositis, after statin exposure, who had these antibodies. And when you do the muscle biopsy, they have the characteristic muscle biopsy of inclusion body myositis, as they were treated, their proximal muscle weakness improved significantly, and what they were left with is the classic pattern of weakness for inclusion body myositis, which is wrist flexion and finger flexure weakness, quadriceps weakness. So the answer is yes, in 2 patients we have seen that.
Any more questions? All right.
Nice story.
Thanks.
So you show that in the HeLa cell, you treat the statin, actually you see this 100 protein increase. So I would expect that in all the patients that later on you show the data that you will see all increase among the patients who are treated with statin, but it's opposite. So how do you explain this?
What's the opposite?
You look at the serum of the patient or people who are taking statin, but you don't see this antibody. Actually, very rare.
That's right.
So, but you treat the HeLa cells, you see huge increase. So how do you explain?
So you mean why is the autoantigen expressed highly in the HeLa cells?
Yeah.
So it's if you treat muscle cells with statins, the levels will also go up. And so why did you see any at all in the untreated HeLa cells? Well, so that's one of the reasons why it took so long to discover this, because it's actually very faint. You'll notice that the bands there that I showed you in the initial IP were very faint. So, and it would vary a little bit from time to time that we did it. It actually depends on how long you serum starve the HeLa cells. So if you don't serum starve the HeLa cells for long enough, they will not upregulate HMG co-reductase. They won't make more of it, and you won't immunoprecipitate it. So it has to do with precisely the conditions of the labeling that allow you to see it in the HeLa cells.
I think we have to continue on.
Thanks a
very
lot.
much.
Sure.